with us.
Hello, happy to be here.
Thank you so much. Okay, so bonjour à tous et à toutes. I'm Anne Lagacé Dowson of the Canadian Health Coalition, which is a civil society nonprofit representing healthcare workers, scholars, and individuals concerned with the defense of universal single-payer Medicare, the much-beloved social program of all Canadians and Quebecers. Merci de vous joindre à nous pour cette conférence de presse sur l'assurance médicaments. So we're here to shout from the rooftops that it's time to bring in pharmacare. It's now. This is the moment. This is something we've known about for 30 years. There have been multiple reports. It's self-evident public policy. Single-payer universal health care and single-payer universal pharmacare are what's required. Canada is one of the only healthcare countries that doesn't have it. So we hope to see this in the form of a Canada Pharmacare Act that will cover the 25% of people who don't fill their prescriptions because they don't have the money. So today we have three speakers. My colleague, Steve Staples, who's the Policy Director of the Canadian Health Coalition. Dr. Jane Philpott, former Federal Health Minister, now Dean of Health Sciences and Director of the Medical School at Queen's University. She's on Zoom. And at this point, I'd like to express my condolences to you on the death of Monique Bégin, who we all admired so deeply. And Professor Marc-André Gagnon of Carleton University, expert en politique pharmaceutique, qui va prendre la parole en français. So, over to you, Steve.
Bonjour tout le monde. Thank you, Anne. My name is Stephen Staples. I'm the National Director of Policy and Advocacy for the Canadian Health Coalition. We are relieved that the government has announced that it will introduce the Canada Pharmacare Act this sitting and will have it passed by Christmas. This week, the Canadian Health Coalition, along with other organizations, ran a full-page ad pointing out that Canadians want pharmacare, but we want the full dose. We ran this ad because we're concerned about the specifics of the new Canada Pharmacare Act, and the government needs to make the right choice. On the one hand is former Liberal Finance Minister Bill Morneau's plan to fill the gaps, which was supported by private insurance and pharmaceutical industries. On the other is Ontario Liberal Health Minister Dr. Eric Hoskin's recommendations for a single-payer universal plan for everyone, which would curtail the role of private insurance and rein in soaring drug costs, which now take as much money as doctors' salaries right now in our health system. Public healthcare experts and organizations like the Canadian Health Coalition support the Hoskins plan for public universal pharmacare. And we're encouraged by Health Minister Mark Holland's knowledge of public health care and experience working for the Heart and Stroke Foundation, one of the organizations that signed and ran the ad campaign this week. So we are looking forward to the introduction of a public universal pharmacare act as soon as possible. I'll now hand it over to Dr. Philpott.
Thanks very much. And I thank the organizers for the invitation to join you for this moment of expression of support for universal single-payer pharmacare. And I'm very pleased to be able to provide some additional comments from a few perspectives. Of course, from the perspective of having been a federal minister of health, and this was some of the work that I was proud to be a part of during that tenure, specifically some important work that we did around the promotion of an expansion of the Pan-Canadian Pharmaceutical Alliance, as well as the work that was done to try to drive down prices of patented medicines, some of which has been completed, but not all. And of course, the beginnings of what would lead us to this opportunity that is now before the government to be able to introduce a Pharmacare Act through initiatives like the establishment of a Canadian Drug Agency, for example. So that is part of my perspective. Of course, the other perspectives that I have are as Dean of the Faculty of Health Sciences here at Queen's University. And I would add to that the perspective of having been a family doctor for almost 40 years now. And it is with that lens that I most vehemently advocate for the importance of getting this right. There are a few things that are as disheartening for a family doctor or other healthcare professionals than knowing that you can help somebody, but knowing that they cannot not afford that help. And as has been already said, we know that 1 in 5 Canadians does not have coverage, and that even those who have coverage, often it leaves significant gaps for them, and they do not fill the prescriptions and therefore do not get the help that they need. People go without the good health that they might have access to, and in fact, have sometimes premature demise based on the fact that they haven't been able to get very basic conditions like high blood pressure or high cholesterol treated because of the expense of some of those medications. And so this is our opportunity as a country to be able to complete some of the unfinished business of Medicare. And one should say that pharmacare is only one part of the unfinished business of Medicare, but it's an extremely important part. And it's a part for which, for a very long time now, there has been strong public support and very strong advocacy, including some of those who are part of this conversation today. We've been waiting for this for a very long time. This is the once in a generation time to get it right. And I strongly advocate that this must be a universal single payer approach and not a fill the gaps approach. If we get it wrong as a country now, it will take an enormous amount of work to undo and to get it back on the path that will allow people to have access to the medication that they need, for the country writ large and individual Canadians to be able to have financial savings that they need, and to be able to ensure that people will get health care. So we don't know what conversations are happening behind the scenes, but I certainly hope that if there are final decisions yet to be made, that they will be made in the direction of a universal single payer approach to pharmacare. This is the time. Thank you.
Marc-André.
Thank you. Merci beaucoup. Je m'appelle Marc-André Gagnon, je suis professeur de politique publique à l'Université Carleton et en fait, je suis en colère. Ça fait 20 ans que je travaille sur les questions de politique pharmaceutique. J'ai plus d'une centaine d'articles, chapitres, rapports sur les enjeux d'assurance médicaments et de politique pharmaceutique. Et ce qu'on constate depuis quelques années, c'est une espèce d'aplaventrisme devant le pouvoir des pharmaceutiques et des lobbies commerciaux au détriment de la population canadienne. Les données probantes sont claires. Un régime public universel d'assurance médicaments, tel que recommandé par le rapport Hoskins, soit dit en passant, le gouvernement Trudeau s'était engagé à respecter l'ensemble des recommandations du rapport Hoskins. Donc, un tel régime public universel d'assurance médicaments permettrait non seulement d'offrir un meilleur accès aux médicaments pour tous les Canadiens et Canadiennes, mais permettrait aussi de réduire les coûts d'environ 20 %. Pourtant, ça fait déjà 3 ans de retard qu'on a dans la mise en place des recommandations du rapport Hoskins. Et là, ce qu'on entend, c'est que le nouveau projet de loi qui serait déposé n'irait pas de l'avant avec un tel régime public universel, mais offrirait simplement une aide supplémentaire à certaines personnes sans couverture, tout en maintenant le système hybride public-privé actuel qui, si on se compare à l'échelle du monde, reste un exemple, un modèle de gaspillage et d'inefficacité. Le problème au Canada, c'est que la couverture des médicaments est un système morcelé, fragmenté. C'est un système inéquitable, inefficace, sans cohérence ou sans objectif d'ensemble. Certains croient qu'on peut résoudre le problème en ajoutant des nouvelles pièces, des nouveaux morceaux, mais le problème de fond, c'est que le système est morcelé. Rappelons que le Canada est le seul pays avec un régime public universel d'assurance santé qui n'inclut pas les médicaments prescrits, comme si les médicaments prescrits n'étaient pas un service de santé essentiel. Au Canada, on continue à penser l'accès aux médicaments en termes de privilèges offerts par des employeurs à leurs employés. Au Canada, le coût par habitant en médicaments est le 2e plus important au monde après les États-Unis, et le Canada reste parmi les pays avec le plus haut niveau de gens qui ne peuvent accéder aux médicaments dont ils ont besoin pour des raisons financières. Les données probantes sur l'inefficacité et le gaspillage du système actuel sont claires. Pourquoi alors les gouvernements refusent d'agir? Et ça, c'est un point qui, pour moi, est très important ici. C'est parce qu'on peut blâmer les pharmaceutiques, les compagnies d'assurance, puis les chaînes de pharmacie de s'opposer au changement. Mais on sent une forte résistance de beaucoup de gouvernements, en particulier des provinces et territoires. Faut comprendre que depuis à peu près une quinzaine d'années, on a mis en place un système de prix pour les médicaments basé sur un système opaque, avec des rabais confidentiels. Les régimes publics des provinces, en fait, ne savent pas contenir les coûts. Elles ont créé un système où est-ce qu'elles peuvent pelleter les coûts ailleurs dans le système. Laissez-moi faire mon professeur Gagnon ici, là. Juste un petit exemple. Le Répata. Si on regarde l'Agence canadienne des médicaments et technologies de santé qui avait recommandé ne remboursez pas le Répata si vous n'avez pas au moins des rabais confidentiels de 90 %. Le prix annuel officiel du médicament est de 6 048 $. Au Québec, les gens doivent payer une quote-part de 33 % avec une franchise de 23 $ par mois. Donc, ça veut dire que quelqu'un au Québec qui aurait besoin du Répata, en plus de devoir payer sa prime de 731 $ par an pour être assuré par le régime public, il devrait payer à ce moment-là de sa poche, en quote-part et franchise, 1 196 $ par année pour obtenir le Répata. Pourtant, le prix réel, une fois déduit le rabais confidentiel, est de 605 $. Donc, la personne va payer de sa poche le double du prix du médicament, en plus de devoir payer une prime d'assurance. Et je veux dire, c'est plus de l'assurance, là, c'est de l'arnaque institutionnalisée. Puis à côté, on regarde les régimes privés. Bien, les régimes privés, eux autres, ne vont pas pouvoir négocier ce type de rabais et vont devoir payer le prix officiel. Donc, en fait, le régime public a réussi, oui, à réduire ses coûts, mais pas en contenant les coûts pour les Canadiens et Canadiennes, ou dans le cas du Québec, pour les Québécois et Québécoises, mais simplement en pelletant les coûts ailleurs dans le système. Donc, à ce niveau-là, tant qu'on a ce système opaque des prix, on se retrouve avec des incitatifs pour les gouvernements actuels de ne pas bouger dans une direction qui serait beaucoup plus rationnelle. C'est inacceptable. Il nous faut un régime public universel efficace, capable de contenir les coûts pour la population canadienne et non pas seulement pelleter les coûts ailleurs dans le système, que ce soit sur les épaules des malades, les épaules des travailleurs-travailleuses, les épaules des employeurs. Il nous faut un régime public universel doté des capacités institutionnelles nécessaires pour s'assurer qu'on puisse en avoir pour notre argent, pour promouvoir des habitudes de prescription basées sur des données probantes et non pas sur les campagnes de marketing des firmes. Il nous faut un régime de couverture rationnelle tel que proposé par le rapport Hoskins. Et je le rappelle, le gouvernement Trudeau s'était engagé à respecter les recommandations du rapport Hoskins. One last thing, maybe. I would like maybe to switch to English for this one. I would like to debunk two arguments, two lies we've been hearing a lot when it comes to pharmacare. First thing, universal pharmacare that will increase taxes, this is bad. I mean, when you want to lower taxes, the purpose of that is to increase the available income for households, for Canadian households. I mean, universal pharmacare would reduce costs for Canadians by 20%. In the end, it will achieve the exact same result than lowering taxes for Canadian households. That would basically increase their available income. Another lie we've been hearing is that, oh my God, if we have universal pharmacare, people will lose their coverage because private plans are much more generous. If you read the Hoskins report, it's not about replacing current coverage. Basically, it's to start covering all Canadians. What it would do, basically, it would reduce the cost, the financial cost of actual health benefits for employers. So that means employers and unions can get together, decide we can maybe increase even more our health benefits. We can get maybe higher wages if you want, higher profits. You can decide whatever you want with this. But it's not about lowering coverage. The current private coverage would remain the same among employers. So stop saying that it will increase taxes and this is bad. Stop saying that you will lose coverage if we go with universal pharmacare. This is not what it is about. Merci beaucoup.
Marc-André also spoke about why the Quebec program, which many people point to as an example of what could be done, is not an adequate program because of the high costs that he referred to. So those people who want more information about the Quebec approach can get the full picture from Marc-André. Merci beaucoup, Marc-André. Vous étiez voluble dans les deux langues. And thank you very much to Steve Staples, whose idea it was to call this news conference. And a special thank you to Dr. Jane Philpott, humanitarian and physician. We're so happy that you could join us today. So now I guess we throw it to the the ink-stained wretches here of the press. And I wanted to say finally, too, thank you so much to the staff of the Parliamentary Press Gallery. They are so accommodating and so wonderful. Okay, so now I guess you should have at it, colleagues from the media.
Dr. Philpott, my question is for you, but I do invite anybody else to weigh in if they wish. I wanted to ask a little bit about the politicization of pharmacare that we're seeing right now. You know, the Liberals have yet to introduce this bill. The NDP have slapped a deadline on it. The Liberals are saying the Conservatives could maybe introduce, delay tactics to avoid it passing by the end of the year. Do you trust our current slate of politicians to handle this issue with the urgency that you feel that it needs?
Thank you very much for the question. And if I may, just before I answer it, let folks know that I will have to drop off the call at the top of the hour. So if I leave, it is not, please take no offense. I have to get to another commitment, but appreciate being with you. This is not something that should be politicized. I recognize that there are inherently political considerations that are underway, particularly as it relates to the agreement that the government has with the NDP at the moment. And I think that is actually to Canadians' benefit, that we know that there are cross-party deliberations about what is in the best interests of Canadians. But we have heard from experts from a nonpartisan, non-political perspective for decades that this is something that is necessary. We've had public policy experts like Professor Gagnon who have weighed in and given good scientific-based advice as to what the path forward is, and there is agreement and a nonpartisan analysis about what is the best way forward. So will politics always be politics? To a certain extent it will, but I would argue that this, like many other decisions that are being made in Ottawa, need to look to those who have done the health policy analysis, who have measured the economics, and that the decision will be made in the best interest of Canadians and their health.
And as a former Liberal minister, the health minister no less, do you think that the Liberals have been too slow in introducing this bill? We've known for a year and a half now that there is this, somewhat arbitrary but also somewhat serious deadline that the NDP have put on passing, not just introducing this bill. They have yet to introduce it. Have they been too slow, and could we find ourselves in a situation where debate around this framework is rushed and not really treated with, the scrutiny maybe that it needs to be?
Thanks for the question. I'm not sure that it will benefit the cause of what needs to be done to assign specific blame to a specific government. This has been, this was in the vision of the founders of Medicare, which goes back to the middle of the last century, that this should be done. And government after government has failed to be able to make this happen. So I would encourage us to think about the fact that just like planting a tree, the best time to have done this would have been 50 or 60 years ago. The second best time is now in 2023. And of course, we all wish that it could have been done sooner. And there's enormous evidence that it would have saved lives. But let's get on with it while it can be done. I encourage the government and their colleagues to be brave and bold and to do the right thing.
David Thurton from CBC. Maybe Mrs. Staples, you could answer this. What is your expectation from this bill? Because in the way some people are talking about it, it's as if we'll get our medications covered once it passes in the Senate and it gets royal assent. What are your expectations? From my understanding, it's just going to lay basically a legal or legislative foundation for pharmacare.
Thanks, David. You're quite right. This is not the big kahuna of pharmacare. It's a positive step forward. It's definitely advancing the basis of further discussions. There's a lot of steps to go in terms of a national formulary, getting up the drug agency, standing up, which is still in a transition phase right now, working with the province. So there's a lot of steps to come. And we're aware of the fact that the commitment in the Confidence of Supply Agreement does not have a fiscal element to it. It's just about getting, as Dr. Philpott said, the foundation correct. Because if we get it wrong, it'll be very difficult to go back and change it. So we're really hoping that when the legislation comes in, and I have no idea, I have no crystal ball, no inside information of what's going on here really in terms of what that's going to be, but we really hope that it is the full universal single payer public option that Dr. Eric Hoskins put forward in 2019.
And are you confident that if this is just a legal foundation, that it just won't remain as a law that just sits on the books? Are you confident that we'll take those other those other steps? Because those are really big steps, those other steps.
Well, you got it. And it'll be a phased-in approach, just like Medicare was. You know, it started in Saskatchewan, and then the federal government took it up, and then eventually it spread across the entire country. But it took a few years for it to do it, and some provinces will probably step forward faster than the others. That's how we imagine it unfolding. But if we get that promise right, but you're absolutely right, this is not the end of the story. There's going to be more work to do, and our organization is committed to doing that work.
Thank you.
Any other questions? Merci beaucoup. Thank you. Thank you, Dr. Philpott.
Thank you.
Thank you, Marc-André Gagnon.
Thank you so much.
Thank you, Anne Lagacé Dowson.
Oh, you're welcome. Bye.
Thank you.